Good morning, all. So today, as all of us know, that we are celebrating celebration of Innovation Week at MIT University at MIT Medical School here, and this webinar is part of that celebrations. So innovations are always look towards the success of any organization or any country. So innovations are always keen, and in the field of healthcare, the innovations are happening every day and every night. So we at MIT are looking forward to see this webinar is going to be focusing on innovations in healthcare. So what are the innovations happening, and what are the science research and development is happening, or what are the possibilities, because most of the postgraduate students and PhD students are there at MIT and across. So whoever is attending this seminar, they will get uh, good knowledge or good from our speakers. So we have Mr. Ajit Bharadwaj sir, and we have Dr. Purushottam Sharma as our esteemed panelist. So I would like Dr. Rajesh Sinha, our director at MIT Medical School, to give the opening remarks.
Thank you, Mr. Gaurav. Uh, Good morning, all the participants, faculty colleagues, research scholars, and students. A warm welcome to the webinar on innovation in healthcare. As Mr. Gaurav clearly mentioned, that this is a part of our Innovation Day celebration, which we do it every year, where we conduct a lot of activities related to innovation. And in this particular series, this webinar is planned. And today we have with us two esteemed experts, Dr. Ajit Bharadwaj. Uh, Dr. Ajit Bharadwaj is founder and director of Optic New Delhi. And we have another esteemed speaker, Dr. Narottam Sharma, who is a senior scientist and head laboratories, DNA Labs, a Center for Applied Sciences, Dehradun. As you all know that the situation with which we are facing since last almost 7 to 8 months because of this COVID-19 pandemics. And this particular crisis actually calls for a lot of innovations in healthcare. And it is not that because of this pandemic only the innovations, we think of innovations in healthcare. Healthcare is healthcare is an area where almost on a daily basis some or the other innovative practices or innovative um, uh, methodologies or innovative modalities are getting practiced or getting formulated. So in this series, we thought why not we should have a kind of webinar where we can where we can create a platform to, for especially for the students and the postgraduate students and the research scholars, those who are connected with the, and also our alumni, so those who are connected with the healthcare, and uh, so that they can listen to the experts and try to identify the areas where the innovations can be done. And in this regard, as I mentioned, we have two esteemed experts. I welcome Dr. Ajit Bharadwaj and also welcome Dr. Narottam Sharma. And I'm sure like this platform which we have created will have a lot of deliberations with the experts, and we will also try to understand what are the areas where the innovations, where there is an opportunity of innovations in healthcare. So once again, I welcome all of you. And once again, I welcome our esteemed speaker, Dr. Ajit Bharadwaj and Narottam Sharma. Now I would request Mr. Gaurav to introduce our first speaker, Dr. Ajit Bharadwaj.
Okay, sir. Thank you, sir. So I just introduce Ajit Bharadwaj, sir. So Mr. Ajit Bharadwaj is a renowned optometrist in India. He is graduated from AIIMS, New Delhi in 1979, and later he completed his master's in optometry from Lotus College of Optometry, Mumbai. He is a founder and director of Optique Vasant Vihar, New Delhi, which has a national retail chain across country. He was the past president of Asia Pacific Council of Optometry and Indian Optometric Federation. He was also a board member of World Council of Optometry and World Optometry Foundation. He is and Optometry Council of India. He was also the clinical director of Special Olympics Opening Eyes program in India. Ajit Bharadwaj is also an avid tennis player, and he has plays tennis for Indian senior tennis team and represents India in international championship. His time in traveling with the Indian team has built his interest in develop the implement of telehealth in his practice, so he could stay connected with his patients now in the time of COVID. So now he is working more on telehealth and innovations in the health delivery during the time of COVID when the social distancing is must. So he has started a vision center in his village, Haryana, and where all patients were provided free consultations, glasses in collaboration with AIMS, New Delhi, Shroff Eye Center, Daryaganj, New Delhi, and Lions Eye Club Eye Hospital in Defense Colony. The center is providing services to 20 villages around the, and optometry interns from Amity also are visiting that center on time to time and participating in their community services. So now over to Ajit sir. So you can, so we will have his valuable words now.
Thank you, Gaurav. And I would like to thank Amity University for establishment the District Collective of Amity Medical School. And it's great for me to be here on a day which is called Innovation Day. And when I heard from Gaurav that this Innovation Week is celebrated to, I mean, in birthday of our founder of Amity University, I couldn't think of a better way to celebrate a birthday because I feel a university in a rural area of Haryana, a rural land of a state which is lagging too much behind in healthcare, is itself an innovation. And I compliment for his vision to establish Amity Medical School in that area where there are no other existing facilities. There is no town close by. There is no city close by, and which is a challenge in itself. And I call it an innovation by itself. Due to my international position in optometry, I have traveled all over the world, all the continents, and visited best of the universities and most of the universities across the globe. And I have no doubt in saying that all the universities are the breeding ground for innovations. And the innovation has to start or starts to be, if you look at the history of innovation, most of the universities across the globe are fueling research, fueling innovation, and helping the community. And I will share my experience of what exactly I see the problem in healthcare, problem in education, and some of the good practices what healthcare can implement by taking those innovation forward. Why I call it a innovation? Because if you look at our Indian economy, over 42% of farmers who are involved in agriculture on a day-to-day basis are only contributing 15% to Indian economy. So what does it mean is this, that there's a huge gap between the input and the output of people. While if you look at the service industry, if you look at the manufacturing industries, the labor or the workforce is divided equally. See, this human resource which is involved in farming, which used to be 52% 10 years back in 2009, and last year's that data I saw, it is 42% last year. It used to be 52%. And if you go back even further, it was used to be even higher. And this is the national statistics. But if I'm sure if you look at Haryana's involvement, Haryana's contribution of workforce in farming or agriculture is much, much higher than 42%. It means there are many, many more people who could contribute to service industry, to the manufacturing industries are involved in farming. And I believe that this is the aim of Amity University, to bring that workforce which is adjoining, which is living in rural areas, into the healthcare resource. And healthcare, if you look at, because as I Gaurav already mentioned, I come from that area. I know the hardship a medical or a healthcare student, when he wants to take a profession, has to undergo. My village is just 30 kilometers from MIT University. It is from Bilaspur. If you turn right, it's called, the village name is Patoda, and it is just 30 kilometers. And I studied there, and what I saw is the status of healthcare or the challenges which I faced. And I'll mention some of you that when I graduated, or when I saw not graduated, but when I passed by, in those days, our 10th used to be matriculation, and then you need to go to college for 2 years, and then you could apply for a medical position of any healthcare. And after 10th, the only possibility, the closest proximity was a college in Rewari. And to reach that college, every morning I had to commute from my village to the station, railway station, which is Patodi Road. From there, I used to take a train to reach to railway junction at Rewari. From there, I used to walk every day. So it used to be 2.5 hours in the morning and 2.5 hours in the evening if trains were on time. So commuting every day for 3 hours for going to your college and coming back. So I feel that this university itself is a boon for all the villages around this area. And what we need to understand is this, that this challenge of healthcare students, people really, if you look at our rural base, I keep very close eye, I keep proximity with the educators and with my students who are still undergoing their high schools there, because I continuously or frequently visit my village. And I see, if you look at the distribution of humanities and arts and commerce, and distribution of non-medical students to medical students, about 60 to 70% of the students, they apply for art subjects, and 30 to 40% students apply for commerce. But if you look at the subjects of medical and non-medical, 85% students apply for non-medical subjects, and only 10 to 15% are applying for medical. What the reason is, and if you look at our healthcare, is so fragmented, is so, the delivery is so poor, because there is a shortage of every healthcare in the country. If you look at nursing, more shortage. If you look at doctors, shortage still exists. If you look at optometrists, if you look at audiologists, there are no hearing aid dispensers, there are no good public health experts. So what is happening? Why, in spite of a population which is 1.3 billion people, we continue to lack every sector of healthcare? And the few reasons which I have gathered from my experiences, first reason, what I think, what is the cause of this, is our knowledge of English. Many students, when they undergo education in government schools, because I under I underwent, or I studied in Hindi medium till 10th class. Till 10th class, I used to study my physics, chemistry, and Hindi. And suddenly, from that 10th to 11th, when you migrate or when you move forward, your every medium is English, and English becomes an alien language for you for many years. Particularly so when you have started learning English for 1 hour for one class after sixth standard. I don't know if the situation is changed, but I started English language learning at when I was in class sixth. And then if you, after 5 years of just 1 hour of class, it's impossible for you to understand what the lecturer or what the teacher is teaching you. As a result, most of the students in village areas don't take English. But the other challenge which I see, why our students don't take English, they find it very hard to cope with. The studies are very long. Number three, unfortunately, our government has been very, I would say, kind of the atmosphere what the healthcare has is either you are a doctor or you are none. The medical dominance in this field has led every other profession of healthcare, whether it is nursing, whether it is physiotherapy, whether it is optometry, whether any care, any stream of healthcare has not been allowed to develop. Unfortunately, the government did not regulate, could not do anything for the healthcare providers for a very longest period of time. As a result, many people felt either you become a doctor or you are just at par with the ambulance driver or any other profession in healthcare, because everyone was classified as a paramedical profession. Everyone was labeled. If you are a ambulance driver in a hospital, you are still called a paramedical person, and if you are an optometrist or physiotherapy, you are still a paramedical person. So that opportunity killed many people to take a healthcare. Hopefully, the government implements AHP bill and gives status to every healthcare in the country, and things improve and things change. And what is more important is that in spite of government's effort in every field, the quackery continues to exist. And that is why many of the students from other, like they don't mind going for BTech, even if they don't know what to do later, but they are very, very scared to take on healthcare professions. So my humble suggestions to everyone around is that we need to create a right ambience and right atmosphere in which every healthcare provider can feel, can live life of dignity, and that change need to come from the government perspective, and hope universities can play a very, very important role in this. We know the shortage of doctors, we know shortage of healthcare professionals, which I already explained. But what I want to tell you is this, that our healthcare delivery, the challenge for even the government and challenge for public at large, the healthcare delivery or healthcare economics, I would say, depends on three factors. And these three factors are: number one, the cost; number two, the quality of care; and number three is the accessibility to the people. Unfortunately, this triangle which exists, whenever any government or anyone tries to work on any area, if we want to improve the quality of service, our accessibility and our cost both suffer. If we give too much of money in the healthcare, the quality improves, but access goes down. If we improve the access, what happens? There's no quality and the cost goes up. So this challenge has to be broken. People need quality, accessibility at a lower cost. And how it can be possible? It can be possible only by innovation, only by changing the way we have been doing things so far. How do we need to do? How can we do this? Or can we really do it? Yes, I feel we can. What we need is to change the way we work, change the way we teach, change the way we learn, and change the way we look at the problems. Some of the problems which I have seen, how people efficiently change. The village I come from, as I mentioned, I was invited to speak on their inauguration day in one of the school which is called JV Public School. I'll give you an example how a student can change and how he can adopt to the changing environment, to the changing facilities which we did not have. I was invited to speak on the inauguration day as a chief guest, the way you have invited me. And after that, I was introduced to a girl. This girl was in 9th standard of JV Public School in my village. And I remember her name was Janvi Pawar. She was in 9th standard and she could speak English fluently with different accent. And when I spoke to her, she told me that she could speak 8 languages, including French, Japanese, Italian, and many more languages. I said, how did you? I said, what is your background? She said that I come from a small village in Panipat called Smalka. And my father is a JBT teacher. And frankly speaking, I said, well, how did you come to this village to study? He said, they offered me free fees. They did not charge me the fees. So that's why I decided to come and study in this school. And they offered me accommodation in the hostel. And I couldn't afford it. So I said, how could you efficiently speak so well? She told me that at that age, she had anchored for BBC and CNN. I later read that she was invited to speak to 150 IAS officers. That how did she learn the language? And when I talked to her more and more, I realized that she was not doing anything different. The opportunity, what she had, which every one of us has, she was using the net. And after knowing more, I'll tell you that there are certain applications which you can tell your students to first. There's a application called Duolingo, Duolingo. This language, this app, if you download it, there's a research done on this app that if you are on this app, if you use this app for 34 hours, it is as good as teaching one full semester of English language. 34 hours of learning and applications can teach you 1 year of English language in a semester of English language in a university or a school. Itself is a game changer for everyone. It teaches you 34 languages, and today 300 million people from 90 countries are hooked to this app. So I would suggest that many people, they don't know. If you look at another app called ALO7, it's an online tutorial for English language which teaches you English interactively. We have to change the method of English learning and teaching. And this girl, if you go and look at the YouTube or type Janvi the Wonder Girl, and you will see that how this girl speaks. And I spoke to her recently and she said that she wants to be a journalist with BBC. So it's a girl from a small village have the dream, and I believe that she will fulfill her dream. I have no reason that she will not. And why she can do, why other people cannot do. So we need to understand that people and students, they come from different background. And what we need to understand that healthcare teaching is very different when they come from different schools. When they come from a school, one student will have a Hindi subject in his teaching medium, other will have an English medium in teaching, English medium of teaching. Their IQ, their level of understanding will be very different level. How can one lecturer teach 35 students who come from 3 different colleges, 3 different backgrounds, multiple different cultures, different schools, the same thing, what one lecture? Is it possible for anyone to learn? Have you seen any doctor giving a lecture or giving a treatment to 35 of his patients, the same treatment? Can it work? And it's not working. I have no doubt in capability of our educators. Some of them are really great. Some of them teach very well. Some of them are very well educated. But the way we teach is poor. We cannot teach one subject to people of different understanding. So what is the solution? The solution, we need to look around, and the solution lies in innovation. There are ways you can detect the intellect. There are ways you can detect the understanding of a student. I would suggest that all the educators look at an application called Squirrel, SQUIRREL, Squirrel AI, and see how you can judge what a child understands and what a child don't understand. When we get why University Grant Commission or CBSE, when they allocate, when they give you the subject, when they give you the curriculum, why can't they take the best of the educators, take best of his lectures, record it and give it to all the universities and all the educators And educators should be there to solve the problems and not just teach what is being already available on Google or any other platform which they can read. In time to come, let me tell you, the students or whosoever will not be employed by what you know, but what you can do to society to solve the problem. How you can implement your knowledge to solve the real problem of the community, of the subject of universities. And it is possible. If we understand what the student is, how can you teach the second subject when he has not understood the basic? What we need to do is that first give him the lesson of basic. I've seen how this app works, how people learn. There'll be 7, 8 students learning different things in the class, and the teacher is only called to just look at the when a child is not able to understand what is being taught. So what we need to understand is this, that we need to understand, we need to personalize our education system. We need to see that every child gets an individual attention by use of the technology, and it is possible and the world is using it. What the teachers need to do, they need to just tell the students how to solve, how to bring innovations, how to do projects. What is need to be done for a university? I was just reading about a university. This university did not have sufficient money to buy instruments in a medical college. And they wanted to teach CPR to the students, how it functions. And they gave a project to all the students. They said, how do we develop it? And one of the students there developed a device, a virtual reality device, where he was imagining that he is in an operation theater and the patient is lying and he has to do CPR. So just by wearing that device, the person is stimulated, he is cut off from the environment in such a way that he is doing the CPR without any device, without any patient, without any operation theater, without anything, just by imagination, just by working. Why this innovation cannot come to universities? If you look at the best of the universities, I was invited once to Oxford. You know, Oxford is the UK's, or maybe I think I would say at this moment of time, it may be the oldest university in the world, if I'm not wrong. It started in the 11th century and continues to exist till today and continues to do wonders. I was invited to not a department of health or not to department of optometry. I was invited to department of physics to speak on affordable healthcare, affordable eye care, not exactly eye care, but affordable vision correction. How we can solve the problem of public by providing the cheapest intervention. And that is the research they were doing in Department of Physics. So the universities today, and when I heard other speakers, most of the speakers, they were from industry. There need to be stronger and stronger correlation, the stronger alliance with the universities of educators, so that they understand what the students, what the country needs, what the public need, and how those public need can be met by the innovation coming out from students. You know, traditionally we have somehow a kind of notion that educators or a teacher should be poor. He should be simple. He should only be doing the academic teaching, or maybe doing only the scientific research. And that is what is in fact become the mandate of our universities, of our medical college, of our IITs. We only produce good doctors, good students, good engineers. But where are our innovations? Even the institutions like IIT, which was built for technology development, very few innovations. The only of late, you will see few products coming out of it, of that institution. I don't see any research coming out from ICMR as far as the startups are concerned, as far as the products are concerned. Only thing what we reach is we are very, very happy if our research is published, and that's all. That becomes the end of an educator's. Why those research can't be converted into products? Why these products which are developed by your university cannot be patented? Why they can't be sold or licensed to the industries? And why universities cannot share that money that comes from those innovations to students? If you look at Oxford or maybe Stanford, number of patents from coming out from those universities, number of research coming out from those universities, number of innovations coming out from them, and they make a huge amount of money, and there's nothing wrong in it. Why should be educators or students should be part of it? I would suggest that all the universities need to change the subjects or the what materials you get, give it to the students in a way that taking best of the faculty's lectures through artificial intelligence to the rest of the country. Take the best of the lecture from one university, which they are good at, teach it in your university. Your university can do what is you are good at and share the resource with other universities, and that is the way to move forward. Some of the students will definitely may come out with solution, and some of them may fail. Some of them may not come out with solutions. That's not a problem. They will fail. But universities and educators need to be patient enough that give them an opportunity again and again and again. The Stanford University is called what we call breeding ground for innovation. This is called Billionaires Factory. Creates billionaires for United States. There are so many billionaires that have come out from that universities. If you look at Oxford, when I was surprised to see that 26 of their students have got Nobel laureate, as Nobel Prize from coming out from one university. 26 British Prime Minister came out from Oxford. 2 of Indian Prime Minister, Mrs. Gandhi and Mr. Manmohan Singh, studied at Oxford. Why those universities are so great? And why we can't create that model of university system here? The only difference I saw, we have everything right. The only thing what we lack is this, that we are not exposing our student to real problems of life. We are not telling them to find out solutions which we can resolve. And I believe that if we change the system, our students, when a girl from a small village can do anchoring for BBC and CNN, living in the same village of Haryana, living in a school in which just the normal student studies, I feel there is a talent, and that talent needs to be converted. And I strongly feel that if there is a way that institutions can change their methodology of teaching, we can bring that innovation to the forefront of our teachings. Innovations can be one of the strongest tool to sell a university. When I look at any university site, I just look at how many research they have done, how many patents they have. And they have a holistic approach to education. They are not just focused on education and educations. 120 Olympic medals get a credit in Oxford University. Why? Because they give sufficient opportunity, sufficient independence to their students. So my suggestion would be that many of educators and many of the founders and many of your vice chancellors will have strong contacts or maybe have better vision than me, and they can bring that in our teaching of using of artificial intelligence, understanding each and everyone's need and bringing them at par and making them successful. Because when students fail in their early years, they become more experienced. And you never know that by the time they are out of the university, maybe they failed in their project, There are many of them, if you look at the startups, when they failed in their students, they couldn't come out with a solution. But later they came out with wonderful solutions. And if you look at the innovation hub in India, I only look at only one city called Bangalore. The amount of innovation, the amount of research that goes in that city is something we need to look at and we need to accept and admire. And most of this is coming from technology students. Students who have done their BTech, students who have done their IIT, they are the one fueling those research and bringing it to us. I was very surprised with an app. This is called, because everyone loves to sing in India. And most of your students will also be liking to that they sing anywhere, they sing in the bathrooms. And it's a very simple application which one of the IIT graduate developed. It's called Riyaz, RIYAZ. And from the very first day you start singing into this instrument, and the application will tell you that this is your frequency which is not right, and this is your note which you have missed. And within 15-20 days, you become a good singer like the singer you want to imitate. And you can sing the song in a much perfect manner within few days' time. There are applications which can use artificial intelligence whereby you can mix your voice with your favorite singer and create a song. There's an entrepreneur in Bangalore. He created a hybrid car. In hybrid car, like Tesla, is being sold for $100,000. And this entrepreneur, within $1,000, he converts your existing car to hybrid car. His company is called RT Green. So these are the innovations which can change. Like if you look at the hybrid car, within $1,000, you save 25% of your fuel and improve 25% of your emission. It's an innovation in itself. So what we need to do is just bring that innovation to healthcare. And I will tell you what are the few of the innovation that has been in healthcare. I'd like to share with you that how we can take it to different field of healthcare, how we can bring it to their use and how others have done it. Once we look at it, it's not a rocket science. It is something, a simple method. The only thing is that we need to interact more with our technology experts. We need to interact more with the data scientists, and we need to see how artificial intelligence can be drawn into this. But let me ask you something, that we are talking about innovation. Why this innovation is now possible? Why it was not possible few years earlier? And what had happened in last few years? See, earlier we had computers which were called 1 to 4 generation of computer, which were very slow, which were very, very bulky. Some of you may have seen the earlier computers. They used to take a lot of space. Even your desktop earlier used to be very, very bulky. But before desktop, if you look at some of the old computer models, they needed rooms with a very little storing space, little memory and little speed. So which are the areas in which innovation in healthcare will happen? Let's understand it. That so far in last few years, innovation happened in technology. There was a migration from analog technology to digital technology. There was development of instruments which were technologically very good, but this development was unaffordable. The cost of healthcare has risen because there were development of very expensive instruments because of technology. If you look at fields like audiology, the hearing aid analog, which were very, very low priced. And when we saw the advent of digital technology, digital hearing aid, the hearing aid were being sold for almost 2.5 lakhs for one piece of hearing aid. And these are the developments that happen in ophthalmology, in any other field, that the technology development led or gave solutions or gave solution or treatment to very few. And this is not acceptable to public or acceptable to the country of our size or to the world at this point of time. We need solutions which are convenient, technologies which are affordable, methods which are practical, whereby people don't have to spend too much of money traveling, too much of money commuting, too much of money reaching the hospital. And this will come from three sources. Three areas which I feel is where the innovation will happen or is already happening. One is telehealth. We are seeing the example that I'm talking to so many students and so many educators sitting in different cities using a Zoom platform. We never revolutionized it. We never thought about it a few months back. But because of the situation like COVID, the innovation has come and it has become a day-to-day, a practical solutions to reach to people, to talk to people. And that has to come into healthcare to a larger extent. Our virtual OPD, virtual care, our virtual patients monitoring, virtual ICU units, virtual hospitals monitoring different hospitals ICU. This is the trend that is happening in the world. There's not so many healthcare providers. So one healthcare provider can see so many patients, so he can monitor so many patients. Devices which can be variable can measure the patient's blood pressure, can measure the heartbeat, can measure the heart rate, can measure the glucose level just by a patch. And those can be transferred to the healthcare provider in real time, sitting in another city. And that's the solution to the problem because it's so affordable, so convenient, so comfortable, and it's so much practical. So this is the area in which the development will take place. Most of your teaching will happen by this methodology in future. You may feel that yes, you are delivering a lecture, but the students could be anywhere or any part of the world listening to your lectures, and that is what telehealth or teleeducation is all about. So one need to see, we are going to do a tie-up, we are going to be looking for universities to connect to my village in Baroda with university students once the universities open up, so that our students who are in doing their post-graduation can provide of different specialty, can see the patients sitting in those remote areas or in those village centers or in other rural areas of the Haryana or other state at a very, very low cost. And this is the area of innovations, whereby you can find different ways to solve different problems of different areas of the body remotely. The second area of growth that or innovation that will happen is called additive technology. What is additive technology is, it's called, in a simple language, it's called 3D printing. And whereby you can print any object at a lower cost, sitting at home without any labor, without any set of multiple devices, machineries, using the technology. You'll be surprised, I used this technology and created this frame, spectacle frame I created sitting in my house. I didn't go step out of my house. Traditionally, this may require investment of 4 to 5 crores. If you look at traditional way of making spectacles, it requires at least 40 to 50 machineries even today to make a spectacle frame. And what I did is created a 3D design, which is called CAD design, and used a small printer and printed the material. Printed this frame myself. I used this technology to print many devices at my home. And this is very widely being used in healthcare, in dental implant, in our pelvic implant, in our artificial limb, all they use this technology now using stainless steel and titanium. You can use different materials like PLA or nylon or polyamide and make sunglasses and spectacles sitting at home. In eye care, if you look at artificial eyes, spectacle lenses, contact lenses, even body organs like artificial cornea can be developed by using this technology. And this is the area with which every product, because once you start doing innovation, you may start looking at innovative products, which may not be available. You want to create a product, what do? You have something in your mind, what do? You design a product and give it to a designer, he will create a 3-cat picture of this and then give it to a printer who can print it for you. So most of the invention will happen in telehealth. Most of the innovations will happen in 3D designing. And third area which is very close, which I very much focused is artificial intelligence. Artificial intelligence looks like, very high, sophisticated term, but in simple language, telling your computers to mimic like a human, to act like a human is artificial intelligence. When you teach a computer that this is what you need to do, and he starts learning it and he starts doing it, it becomes the artificial intelligence. And I will share some of the technologies used by various universities. Most of the research in artificial intelligence is happening in universities. A university is in UK in Birmingham called Aston University. The maximum money on a healthcare, if you look at any intervention or any disease which takes on maximum expense of a patient, if you think about it, it may not be your heart, it may not be your heart surgery or any knee replacement, which is dementia. It takes a lot of money to treat a patient with dementia. Because we are not able to diagnose diseases like Parkinson's. And some mathematician sitting in Aston University in Birmingham, what he devised is, in Parkinson's, what happens is that your ability to speak goes down. You are not able to speak, your frequency goes down. What he devised a simple technique, and he started doing like in front of your patient, in front of your mobile phone. And patients who are prone or who may develop dementia, Parkinson's in later stages, they could predict the behavior on, we call it speech recognition pattern by artificial intelligence, and can predict that this patient will have Parkinson's. What happens more in Parkinson is your walking pattern gets affected. So if they asked many patients to walk with the mobile phone and they understood the pattern of walking, and they diagnosed that this person will have Parkinson. And this is done by mathematician students of mathematics. We are students of healthcare. I'll give you an example of oral cancer. Needed lots and lots of investigations. What these students did, they took the picture of the mouth. And just by looking at different colors, just by understanding the different changes in cancer in the mouth, they can predict that this person has an oral cancer and this is a normal cancer. This patient is normal. So technology is taking us to a very different level. The normal CT scan, if you take, it takes almost 2 to 7 hours to do a CT scan and get the report. Whenever you undergo a CT scan or MRI, it takes a very, very long step to diagnose. Using an artificial intelligence, you can diagnose patients. You can diagnose diseases in 10 to 15 seconds. I was in China recently playing a tennis tournament, and I went to a school. And you know how they take students attendance in the school, in the class? The teacher comes, he will start his mobile phone, take the picture of the class, and he will know immediately that which student is absent using the facial recognition. He doesn't take attendance in the class. The process which takes 40 or 50 students to say yes, no, is minimized by some seconds using the facial intelligence. Countries like China is using facial intelligence for every financial transaction. They don't use credit cards. They don't use any other device except their face. Their face is their credit card. They stand in front of the computer and they put a QR code and the money is deducted from the account for whatever commodity they want to buy. Nobody uses cash in China. Whether it's transportation in a metro, whether it is transportation in a bus, whether it is buying a 1 kg of potato, everything is through artificial intelligence. And this facial intelligence, what is being used for them to detect crimes, to catch criminals, to detect offenders, is something that we need to innovate. We are using this for diagnosing of diseases, which is the same technology. Taking pictures and putting them in a computer. You know, it took only 50 pictures of patients for him to come out with the artificial intelligence software to diagnose the oral cancer. Only 50 images. So if you are a healthcare provider, I'll tell you, all of us can become an entrepreneur by just taking pictures of many patients using artificial intelligence, which is available on cloud free of cost. There's a software called AutoML in which you can put on your pictures, you can teach a computer that this is a diagnosis for this picture, this is a diagnosis for this picture, this is the diagnosis. And very soon you realize that computer start giving the predictions. This is how the technology is moving forward in different areas of specialties of healthcare. I'll share some of other examples particularly in eye. You know, the artificial eyes, sorry, not artificial, but dry eyes we used to detect using Schirmer test or using BUT test by putting filters in the eyes and using the dye, which is fluorescein and lissamine, and then we could predict how the tears are. A simple instrument which just measures the temperature of the eye and gives the result that this patient has a dry eye or not. The thermometer which is used for COVID is used for detection of dry eyes. Only difference is this: with the temperature, it gives the picture of the eye, and the eye which is having normal will be showing you green with the lower temperature, and the eye which is showing with the high temperature with dry eyes will show in the red. We were looking at different investigations. We used to take a lot of 24 hours to get a COVID test. In China, the patient went for an MRI of lungs, and within seconds, the computer told us that you have a COVID, you need to be isolated or not. And these are the intervention which is not something which cannot be done in India. If you read more about Google's alliance with Arvind Eye Hospitals or Shankara Nithalaya, because we have a lot of patient data. We are rich in data because of the population, because of number of patients our hospitals have, a number of students our university have. So we are data rich. So Google did tied up a research with Arvind Eye Hospital. They took 130 fundus camera images to detect diabetic retinopathy. They hired 54 board certified doctors from US, retina specialists in US, and they started grading them. They had no problem. All the doctors, they agreed on whenever there was no diabetic retinopathy or when there was a proliferative retinopathy which was leaking. But when it came to grading the diabetic retinopathy, most of them did not agree. The Google data scientist, she was leading the project. She said that 65% of the time, the doctors did not agree whether it is a mild or whether it is a moderate or whether it is severe diabetic retinopathy. So they went by voting that when there was a diagnosis, they went that who is what the majority says, and they said they took that diagnosis for the computer for making the software and making the artificial intelligence. And what happened is this, that sometimes he said that the same doctor who predicted that it is moderate diabetic retinopathy, the next day we sent the same image and he said, no, it's not moderate, it is severe. So human interventions can change, but artificial intelligence stays the same. The results are always uniform and results are predictive. And you'll be surprised that what computer starts learning, our doctors never saw. They started learning that the computers later, they started doing more research on fundus images, and they started to realize that they could diagnose whether the person is male or female, what is the age, average age the computer predicted within 3 years of accuracy. The same retinal image which is only used for diabetic retinopathy or for glaucoma detection was being used to detect whether this patient will have cardiovascular risk in time to come or not. Whether the person will have a stroke or not, whether the patient will have Alzheimer or not. This can all be predicted using the same image which was only being used for a particular cause. You know, when our patients develop osteoarthritis in old age, our doctors only diagnose when patient has a lot of pain. But artificial intelligence uses just a picture and observes the fluid between the cartilages and predicts osteoarthritis 3 years prior to its onset. Most of the deaths in the hospitals happens because of sepsis. Patient go for one reason, he develops infection and he dies because of sepsis. And today, just looking at the blood report, feeding various blood report in the computer, in the artificial intelligence software, you can predict whether this patient may have sepsis 3 days prior to its onset. And in sepsis, every hour counts. So this is the way the artificial intelligence is leading forward. And this is the area where innovation will happen. Gaurav, can you look at the time and see if I need to stop, or I'm sure that I don't want to go into another speaker's time.
Yes. So we are already exceeded little more.
So I think I need to close, but I will just tell you one thing, that within next 10 years, many of the jobs, whether we do innovation or not, but the innovations will be here. Whether we like it or not, it will happen, and it will displace many of healthcare providers. It will displace many jobs. There is a virtual nurse today created by MIT. There is a virtual nurse today created by another institution. There's one nurse which is called Moily. You can look at the net. There's another nurse which is named as Lousy, Louiusc. Two nurses, one, they're doing different jobs. But let me tell you, nursing will never be replaced, because nursing involves much, much more of elderly care, compassion, the sensitivity, the communications, the interaction with them. So any profession which will have compassion, which will have empathy, which will have understanding, communications, HR, human resource, your public health, your public relations, where there is human to human interventions, and most of the healthcare profession lie in those criteria. But professions like radiology, professions like dermatology, pathology, they are at severe risk of being replaced. I'm not saying they'll be replaced or they'll be out of job, but they need to relearn their subject once again and move into different areas of speciality and do something better. So with this, I would like to close, because I can talk much on this. This is my subject which I love from my heart. I can talk for hours, but looking at time, I would like to thank all of you for inviting me. And I hope some of these suggestions don't get offended if you are educators, but this is really what I mean, and this is what is the need of the hour. And thank you once again for inviting me and being here. Appreciate
Thanks
that.
a lot, Ajit sir, for the wonderful session. Now, I would like to invite Dr. Vijay Sima sir to introduce our next speaker.
Before Dr. Vijay introduces the next speaker, I just highlight some of the points. Thank you, Dr. Ajit, for such a speech, and definitely it would have motivated our students, scholars, even the faculty also to ready for the innovation, not get ready, but now you have to adopt innovation in your practice. If you want to sustain in the market, if you want to sustain in the industry, innovation to be adopt innovation as a culture. Um, uh, you have very simple way you have highlighted some of the points, especially with respect to the challenges in healthcare. You have mentioned three factors which is really affecting a lot in terms of cost, quality, and access. And they have given a lot of examples related to the three areas where the innovation is getting practiced in healthcare, especially with respect to the virtual reality, adaptive technology, and also the artificial intelligence. And the examples which you have given is truly available, are truly acceptable in the healthcare industry. And there are a lot of things which you have clearly mentioned that this is which is existing. And the last point which you have made is very true. If we want to sustain, if we want to have a position continuing in the healthcare industry or in academic institution, we have to adopt innovation as a culture in our day-to-day life. Otherwise, as you mentioned, like the machine will take over, and definitely getting sustained in the industry, as whether you talk about the academics or the healthcare. Thank you so much, Dr. Ajit, for your valuable feedback or the valuable suggestions, and your content of your lecture was excellent. All participants would agree to this. So now I would invite Dr. Vijay to introduce the second speaker. Sir, Dr. Vijay, over to you.
Thank you, sir. Thank you for giving an opportunity to introduce Dr. Navratna Sharma. Dr. Navratna Sharma, a senior scientist, head laboratories, DNA lab, a Center for Applied Sciences, Dehradun, Uttarakhand. The lab is an ISO certified laboratory. Dr. Sharma completed his MSc Biotechnology from HNB Garhwal University, Srinagar in 2008. Dr. Sharma completed his PhD in biotechnology from Banastali University, Banastali, Rajasthan. There are so many awards received by Dr. Sharma. I'll like to mention a few. Dr. Sharma received Young Scientist Award in 12th Uttarakhand State Science and Technology Congress held in 2017 and 18 in discipline of medical sciences, including pharmaceutical science, organized by Uttarakhand State Council for Science and Technology. Dr. Sharma contributed many research articles, both at national and international level. He was awarded with Best Oral Presentation at first annual conference of the Indian Academy of Biomedical Science International Symposium on Advanced Applications of Molecular Biology and Clinical Research at CSM College, Lucknow. He received Gurudev Singh Award for Honesty and Courage, Chandigarh. He awarded for the distinction and installation of that Biosafety Level 3 laboratories by Honorable Chief Minister Surendra Singh Negi in 2015. Many awards and rewards at different levels. Dr. Sharma is one of the best and leading molecular biologists in Uttarakhand, and he has his own laboratory which is devoted for research and training for students. I would like to welcome Dr. Sharma. Please, Dr. Sharma, take over from me.
Thank you. Thank you very much. So it's a great opportunity for me to talk on behalf of DNA Laboratories, Dehradun. So I'm very grateful to Dr. Rajesh Kumar Sinha, sir, Dr. Gaurav Kumar, Dr. Ajit Bhardwaj, sir. He is encyclopedia I have heard him uh, recently, and Dr. Vijay sir from Medical Lab Technology Department. Actually, last year itself, I was there in Amity, Manesar, for as a external examiner in Medical Lab Technology. One this examination. So. Basically, I was working here in Dehradun in medical college, and I left in 2019, and then we started so many innovations. So because leaving the job and then uh, tackling with this COVID, it was very difficult for me. So from the past, I think 5 to 6 months, sir, can you make me a host so that I can share the presentation, because so many medical lab technology students are there. So I would like to share some of the slides with them, like the innovations in health sector, disease, and in other biomedical related professionals, what are the basic opportunities, and what is this COVID has given to this biomedical professionals as well as this medical lab technology students. So uh, basically, this when we talk about this innovations, especially sir has already talked about the innovations in teaching, training, research in another disciplines also. But recently, if uh, we will see this pandemic, like from March 2020 to till date, so many innovations have already done. You can see, like in India, the diagnostic laboratories, which was only 100 or 115. Now, after this one, it is 667. So this has given the COVID like how to at least accredit and how to be prepared for combating this highly infectious disease. So basically, when we talk about this innovations in science and technology, like in Zoom and all, without traveling to Manesar, we are able to at least contribute our this presentation from Dehradun itself. So I will be focusing on the characterization of the various disease and disorders, some of the carcinomas, and what are the various innovative technologies that is playing a vital role in current scenario. Especially, I'm talking about Indian scenario, not from USA, from another these all from to another countries. So, what is basically happening in India? I will be sharing that part only, and what actually we are doing, and how the Indian scenario is getting into the soup of this one technology driven sciences, right? So when we talk about disease diagnosis, especially this one, various you can see like this virus, this coronavirus. Earlier it was swine flu virus, before it was sark virus, mers virus, bird flu virus. So the latest technologies that has emerged is molecular diagnostics, cellular and molecular diagnostics. So basically, some of the tests, some of these things have been outdated, and they have been replaced by these novel technologies. Simply, when we talk about, I think so many participants are from medical background, so they will be knowing like what is basically this molecular diagnostics all about. When we qualitatively or quantitatively detect this nucleic acids, DNA, RNA, or in some of the cases the expression of the proteins also, that is molecular diagnostics, right? So there is no need of doing another test. So this is actually the point of care. So when we talk about the personalized medicines, that is in current scenario, one order, one test. There is no need to write down so many tests. For example, for COVID-19, you can see only gold standard one is real-time PCR. For H1N1, you start with Tamiflu and Oseltamivir. These are antiviral drugs. So some of the net technologies are there, which is equipped with molecular diagnostics. So one result, one interpretation, and one clinical applications. So there are so many things that is happening nowadays in India, right? Firstly, I would like to talk about some of the sexually transmitted disease and the innovation technologies that is happening right now in Indian scenario too, right? When we talk about some of the carcinomas like colon cancer, rectal cancer, breast cancer, cervical cancers, or some blood bone cancer like blood cancers and all. So novel technologies are there. There are so many innovations. There are so many things that is existing in Indian scenario too, that is taking care of all these for characterization, for diagnostics, for treatment. This one, right? So in India, basically, from the past 10 years, these nucleic acid amplification technology, or what we are saying that this DNA and RNA based technologies, that is much in demand and is being utilized for the routine characterization of the cervical cancer. Because in female, this carcinoma, this cancer of the cervix, it is very, very important. And the causative agent for this one is human papilloma virus. And this is epitheliotropic virus, and it is also called a shy virus, because the basic and a very important and the good one of this virus is that without causing any clinical manifestations or the clinical changes, it can stay at least for 5 to 10 years. So the patient will be having, or the female is having 5 to 10 years to routinely screen out for this viruses. And how it is being characterized by the innovative technologies, I am going to explain. So this is human papilloma virus. It is double-stranded circular DNA containing virus. And in India, when we talk about this cervical cancer, and 1 out of 4 women die to cervical cancer in India, right? So every 7 minutes, one Indian woman dies of the cervical cancers. It is preventable, and the problem with this cervical cancer is that it has more than 100 types of its types. Human papilloma virus, basically, it is of so many types. Like Bethesda system of nomenclatures, they have classified this human papilloma virus into low risk category and high risk category. So low risk do not cause cervical cancer, and high risk it causes cervical cancer, and these are very important one. So at least to characterize so many types in a single platform, chip based, gene on the chips, DNA based technology, DNA microarrays, hybrid capture, DNA RNA hybrid capture assay technologies are there, which can characterize the more than 16 types of high risk HRHPVs, that is called high risk human papilloma virus oncogenic types in within a same day. Because virus, it is very difficult to culture, it is very difficult to detect also. So novel technologies, they are doing good work. You can see like the most important one, type 16 and 18, these are responsible for the cancers. So this is basically the flow diagram, we can say, depicting like how the innovations have been done in the characterization of this novel coronavirus. And this professor Hazard Zone, he got Nobel Prize for this only in 1982, right? So this is again very important, because there are some of the disease. For example, if an individual is with HIV, human immunodeficiency virus, if an individual is with liver carcinoma or hepatocellular carcinoma because of hepatitis C virus or hepatitis B virus, and the female is with the cervical cancers, right? So there is big difference between its clinical results interpretations and how it should be characterized. So it is a very important one. For example, one HIV, if it is there in the female, it can be very lethal. But if it is one HPV virus, it clinically it is not that much relevant. This is actually a very important one when we talk about its clinical relevance, right? So it is clinically advisable to detect one single copy of HIV. Yeah, very much correct, right? So, but when we are talking about this human papilloma virus, because it is a shy virus, it slowly grows in the cervix and used to damage the cervix. So the further customization of the treatment, as well as duration of the treatment, as well as routine follow-up for the females also, it totally requires the copy number of this human papilloma virus. So DNA RNA hybridization technologies, they have they are very beautifully detecting how much oncogenic circulating tumor HPV is there, so that it can be characterized, right? So these are basically the gradings of the cervical cancers. Because from the past 10 years, I'm working on in molecular testing, also in molecular diagnostics also, and we have established this laboratory. So there are different types of stages of the cervical cancer when we talk about this one. You can see the sin 1, sin 2, sin 3 grading, right? And if you can see this picture, it beautifully depicted like this virus can shed off automatically also. For example, if a female is with HPV infection and it is just in initial phases for an average of 6 to 9 months, automatically she can shed off, and that infection can grow further, right? So on an average of 6 to 24 months, where there is actually the damage of the cervix, because the most important host for this viral infection is squamous epithelial cells, they will start degrading, right? So this is called as cervical intraepithelial neoplasia grading 1, or LSIL, low grade squamous intraepithelial lesion. So in this stage also, when you are getting to know like this female is with HPV this much copies, so they can be at least treated, or the treatment can be customized, right? So sin grading in sin 2 and 3, at least in these are basically the gradings of the cervical cancer. High grade squamous intraepithelial lesions, here are also the chances that the female can get recovered, right? So you can see like the female is with 10 year, on an average of 10 years, so that she can at least take care of the cervix if it is infected by this human papilloma virus. It is not like, for example, initially when she get infected and within 2 or 3 years she will die. No. So routine screening of the cervix properly as per gynecology guidelines, as well as molecular testing with this hybrid capture assay, make this disease as a this one. Okay, so this is again very important. Like you can see the gradings of the cervical cancers, how much it can regress and how much it can progress. You can see like in all the types of sin 1, sin 2, sin 3 grading, regression rate 57, 43, and 32% respectively. And progression rate, you can see like in sin 2, it is 22%. So we have the enough time so that we can at least come back from this infections. Okay, when we talk about the innovations, so from the past uh, 10 to 15 years, the molecular diagnostics had changing, has means 70 to 80% they have entirely changed the diagnostic algorithm of some of the disease. So it is a very important one, like how we can at least characterize this disease. So this is basically the technology, because this virus is a DNA containing virus. So what actually we used to do is we used to take the DNA and hybrid it with RNA. For example, the female is with high risk human papilloma virus, and we can screen out all the types in a single day also. So this is basically the protocol from the QIAGEN, right? You can see this is a basic protocol how we can do. So hybrid capture assay technology, hybrid capture assay second generation technology. You can see like medical lab technology students, they will be going for internship training programs and other training programs also. So Dr. Lal, Renbexy, Religer, Metropolis, Petkines, this Ames of the Jung, Lady Hardings, they are equipped with all these technologies now to rule out or to screen out this cervical cancer on a routine basis. Fine. So we are detecting this HPV DNA, as well as we are going to quantify this one. Okay, so there are also so many other methodologies also that is there, but this technology, at least it is covering the whole genome. For example, if there will be any mutations also, right? So you can see like this hybrid capture assay technology, which is a new innovations, it is going to cover the full genome probe, so that any kinds of misleading results or any kind of the false results will not go to any of the patients, so that it can be characterized properly. If you are simply going for another PCR technologies apart from this hybrid capture assay technologies, so there can be some of the portions that may be missing, or that may be deleted, or that may be mutated, so that so it will not be covering the entire genome. But in case of HCA2 or the second generation technology, it is covering the whole one. Fine. So this human papilloma virus, it is going to have this advantage that it can pick the minimum amount of HPVs also, which is clinically relevant. I I think you have heard about you, because you are from this biomedical professional. You have already done this chemiluminescence protocols as well as these ELISA reader protocols and all. Likewise, this DNA based technology is same, fine. So it is basically taking out the DNA from virus and hybridize it with this RNA primers so that we can see the results, right? So basically it is a luminometer based technology where the chemiluminescence will be observed and the results will be interpreted in terms of copies of HPV DNA, right? So this is the basic protocol also. You can see in you can Google also, like hybrid capture assay for human papilloma virus. It is also for those microorganisms which is difficult to culture, which is difficult to detect. Say for example, other sexually transmitted infectious agents like chlamydia trachomatis, Neisseria gonorrhea, that can be, they can be also done by this thing, fine. So say you can see like a patient can reduce the frequency of going to the doctor if we are utilizing the innovative technologies to routinely screen out. You can see like cytology, because cytology is basically to screen out the cervix by gynecologists with the help of taking out the cells, right? And for example, pap smear test they used to do, right? Visual inspection also. When we talk about this thing, you can see like there will be the reduction of 53% lifetime, 6 lifetime screening. That is 53% reduction in incidence of cancer as well as 47% reduction in mortality. And there is no need to at least go to the doctor frequently for this cytology as well as visual inspection too when we are going for this HPV testing. So new diagnostic algorithm that is in a whole India, that is being practiced by gynecologists and there's obstetricians as well as in this cancer institute, is to at least club up the this cytological findings as well as this human papilloma virus findings to rule out the cervical cancers or the chances of getting the cervical cancers, right? So in this way we can at least reduce the frequency of the screening also, right? This cancer is 100% preventable in the initial stages itself, right? So these are basically the new, I will tell you like what is basically how the technologies has come into the market or come into this one in medical sector and and has changed the diagnostic algorithm and has changed the diagnostic platform. For example, if the female between the age group of 30 to 64 year, if with the new diagnostic algorithm she's being screened for HPV test, if it is negative, no need to come at least for another 5 years, because there is no need to at least recall that patient for another 5 years. If it is positive, then we can go for visual inspection. If visual inspection is normal, within a year or within 2 years, we can again go for HPV screening, right? And if it is abnormal, then the quick treatment is required. So this is basically the new diagnostic algorithm which is given by the Bethesda system as well as Cancer Society to rule out or to screen out the cervical damage or the cervical cancers. So this the technologies, the innovative technologies that was there in to rule out this was hybrid capture assay, then this nesba transcription mediator amplification technologies. There are so many things that is into this one. A little bit I will be talking about tuberculosis, because in India, you know, this there are so many means we can say like it's epidemic. Tuberculosis is an epidemic and one of the most important bacterial infection, that is an opportunistic infection, and it is giving rise to another disease also. How the new technologies has replaced the orthodox one and how it can be significant to screen out, to diagnose, to treat the multiple drug resistance in case of the tuberculosis also. So Robert Koch, the discoverer of Mycobacterium tuberculosis, it is a gram-positive aerobic rod-shaped bacteria, and this bacteria it is causing TB, tuberculosis, right? So there are so many types of this one, and because this Mycobacterium bovis, Mycobacterium tuberculosis, Mycobacterium jeugeni, Mycobacterium microti, Mycobacterium avium paratuberculosis, Mycobacterium. There are so many types of Mycobacterium that can cause tuberculosis. When we talk about diagnosis, so earlier what actually we were doing is till date also, this is basically the Zn staining, or it is also called as acid fast staining, which the students are also doing their during their dissertation program as well as in the college level also. It is a gold standard to screen out, or it is highly specific for to rule out this acid fast bacteria, right? And fluorescence acid fast microscopy, it is also there for this one, right? And when we talk about the culturing of this bacteria, from the past 15 to 20 years, it was being cultured on this algae media, Lonstra and Jensen. Now with this technologies also, there is now automation in the cultures. Earlier it was radiometry culture, because of the radiometry this radioactivity issues, it was banned also. That Bactec 460, I think you have students have heard also this one, like Bactec 460 culture system for this Mycobacterium tuberculosis growth. Now it is a fluorescence based culture methodology, which is right now for culturing of this slow growing bacteria, which is called as this one NGIT, micro growth indicator tube, from this Germany based company. In India, if you are doing the culture of Mycobacterium tuberculosis, for example, for routine characterization of for quick recovery of the bacteria with good sensitivity and specificity, we can go for this MGIT, that is micro growth indicator tube, that is liquid culture. And when we talk about the solid culture, still this algae media is also there, Lonstra and Jensen's, right? So these are basically the tuberculosis skin test. Now it is not being for routine diagnosis of tuberculosis, it is not being done nowadays, right? Okay, so a serological test, for example, earlier means before 5 to 6 years, it was like the serology of IgG, detection of IgG and IgM in case of this tuberculosis, but they were giving false results because of the cross reactivity and antibody responses late in human bodies. And this was there are so many kits that has been banned by government of India, at least for the false fluorescent sorry, false results in case of the tuberculosis. You can see like it was published in so many newspapers also. So in accurate serological blood test for the diagnosis of TB, which was banned by Ministry of Health and Family Welfare, government of India also. So now this is basically the innovations also when we talk about this molecular characterizations. So these are the novel technologies. What actually the patient required if it is with tuberculosis is, first it's diagnostics, then what drugs should be prescribed. So both the things is being answered by this molecular biology tool, right? For example, TB bacteria, it can detect in single day. There is no need to at least culture for another 4 to 5 weeks. Then for example, if the patient is under anti-tuberculosis treatment and doctor prescribed him or her to at least go for drug sensitivity or susceptibility tests. So there are now the gene expert as well as other technologies also that can tell like this drug is resistance and this drug is susceptible. So it is a very important one uh, for the characterization of Mycobacterium tuberculosis in tuberculosis patients. Fine. So you can see like this is basically the whole molecular markers that can be utilized for the differentiation of the different kinds of mycobacterium types, right? So for fast grower and slow growers, you can see like there are molecular markers, fine. RPOB gene, 16S rRNA gene, DNS genes common are there, right? So we can differentiate as well as characterization on a species levels also on the basis of the genetic makeup of this mycobacterium complex, fine. So you can see like this is how we used to do, right? So when we talk about Indian scenario, it is very important to give the correct reporting as well as the report which require the basic genetic composition of that bacteria or that bacilli that is present in that individuals. So when we talk about the copy number as the most important molecular markers that is present in Indian scenario as well as in Indian subcontinents, so this is called as Mycobacterium tuberculosis complex, which contains the members tuberculosis, bovis, canity, africanum, and microti. So MPV64 and IS6110 genes. So these are the molecular markers which these companies are routinely utilized for development of the new kits, developments of the new diagnostics assays also, which is in high copy number, as well as these are the conserved sequences in Indian subcontinent also that can be utilized for its characterization, right? So these are being utilized by the companies here, right? So this endpoint PCR and RT-PCR, now it is a very simple technologies that this technicians and the scientists are routinely utilizing in molecular diagnostics labs, right? So now it is an updated version of the PCR only, RT-PCR. आजकल देख रहे हो, for example, you are going out from your town, you require RT-PCR report for COVID testing. So real-time PCR is nothing but it is also an instrument that will detect the copy numbers of a target gene in a single time in a same machine. There is no need for the post amplification technologies also. So we used to train all the students in these conventional PCR or endpoint PCR or a real-time PCR technology in our labs also. So for virology, at least for virus characterization, for example, H1N1, bird flu, this influenza for SARS, MERS, and this one, it is a gold standard. RT-PCR is a gold standard for the routine characterization of this one, right? So these are the new technologies, and now there are automations, fully automations and semi-automations in instrumentations also, where from sample collections, after sample collections to results interpretation, a single machine is doing. So this is basically the Mol Bio from Tulip brand, and they're doing good work in India. So I'm not promoting any of the firm or any of the laboratory over here. There are also n number of the companies in molecular diagnostics like Roche, Kaizen, Techman Coulter, Bioreds, Cepheid, Gene Expert, Amol Bio, 3D Black Biotech, My Labs. There are so many n numbers in India. I'm talking about Indian scenario, which companies are working in molecular diagnostics, right? So the automations and the chip-based diagnostics, because now it is a lab on the chip concepts. So there is these are such instrument. For example, if there will be any pandemic in the remote area also, it can be operated by your car batteries too. For example, if there is an outbreak in any of the village where it is very difficult to establish the fully fledged biosafety laboratories as well as with all the equipped instruments and all. So this is basically the lab on the chips, right? So multiple infectious parameters can be characterized in a single day. This TruePrep, TrueNet, you can see like in ICMR guidelines also, it is approved machines along with this Roche and all. So these are basically the things that is happening even for Mycobacterium tuberculosis. For dengue also, dengue yeah, earlier in every year there is the wave of the dengue too after rainy season. So the molecular methods, it can routinely characterize the disease. Even they are detecting the different serotypes of the dengue too. For example, serotype 1, serotype 2, serotype 3, serotype 4, and all. So 4 serotypes it is going to characterize in the same assays. So this is also being done for chikungunya. We are utilizing BCR radial, that is breakpoint cluster regions. This is basically the picture of our laboratory. We are routinely characterizing the infectious disease, as well as we are doing some teaching and training work also. So here we are about to get associated with government of Uttarakhand to provide the support to screen out the COVID-19 patients also. So cellular and molecular biology laboratory, it is with DNA labs, where we are doing the characterization of Mycobacterium tuberculosis, HLA sequencing, then human papilloma virus routine characterization and all. Basically, this is the picture of a typical picture of real-time PCR, how this fluorescence based real-time PCR has means how it is coming into the market and how it is going to characterize the different viruses, different bacterial disease in a single time, right? So there involved, there can be different chemistry of the real-time PCR. One is fixed plate real-time PCR and one is a rotor based machine. So there will be, like for example, in a single run you can test 96 to 100 samples of swine flu or this coronavirus and all. So this is basically the inner chamber of this real-time PCR. It is a fluorescence based chemistry. We will be utilizing the probe based mechanism for the characterization of the disease, right? So we are with this RT-PCR from Kaizen, where we are utilizing this one for routine characterization of the disease, right? So I will skip up all these slides. We are also missing the students to come to the lab because it is lockdown. We are unable to at least give the training, specific training, hands-on training to the students. And this is basically our laboratory team. So it is better to stay in one or two fields also. So we are in diagnostic, teaching and training. And I would like to show uh, some slide of sir was telling, like innovation can happen whether you want or not. That is that is actually very much correct, right? Because we are in our hand, it is not like we cannot stop this thing to happen. So another one is like necessity is the mother of invention. So when this lockdown happened, what actually we did is we started providing the practical exposure live from the laboratory. So from April onwards, so we have started the e-laboratory, e-prayogshala, e-virology labs for the students. So this was also innovation from the DNA laboratories too. So we used to provide the soft copies of the training manuals to the students before starting these programs. And with this clinical and diagnostic virology, these are all online concepts. So only means a live demonstration of the practicals as well as these things to the students. We have already means organized all these programs from the past 4 to 5 months. So e-prayogshala was there, e-industry program was there. So it was, I think, the concept from the DNA lab itself, where more than 500 students have means completed their short-term training, even this dissertation training programs from this laboratory. So thank you very much. Thank you, Amity University, and all the respective faculty members for giving me this platform to interact with the students. Thanks.
Thanks a lot, Dr. Narottam, for enlightening lecture and very much informative session. And our students will definitely get a benefit of your lecture. And it is the best thing to see that e-prayogshala is also available now. So it is the need of now, because most of the universities are not functional and labs are closed. So it will be better if we have certain tools like this, which a student can learn online or online platform, the same practical which they are doing in their labs. So that will be more better nowadays, because once the universities are open, then things will be different. But at present, it is the maximum needed thing, and which is the highest, best innovation which we can do. And I will just like to say, Rajesh sir, would you like to add something?
Thank you, Mr. Gaurav. Yeah, you rightly said, like especially e-prayogshala and definitely the online platform, which definitely assists the students to learn a lot, and almost most of the university now moving towards this. Thank you, Dr. Sharma. You have enlightened us, especially the students would have learned a lot actually from your presentations, because the content which you have shown and innovative practice which you have in the lab, the state of art facility which you have shown, definitely that would have allowed our students to learn a lot. Especially your presentation was very focused, and it was definitely it was more of scholars related or students related, or very research related thing. And you also rightly said, like, innovation definitely has to happen. And if we really want to grow, definitely we have to live with the innovations. We have to live with the innovations. That is what the need of are actually nowadays. Because especially in the healthcare, when we talk about providing quality healthcare services to the patient, and that is only possible when you have a proper diagnostic facility, and the lab which you have shown, the way these diagnostic facilities are actually helping to provide quality healthcare to the patient. It's really marvelous and excellent. So thank you so much for your time. For both the speakers, I wish to thank Dr. Ajit and Dr. Sharma for coming and sparing your time. Especially, I saw Dr. Ajit also was listening to the entire presentation, and like, because many times it happens where because of lack of time, speakers may leave, but I saw Dr. Ajit was also patiently listening to the entire presentation of Dr. Sharma. And both we are actually fortunate to have both of you in our this webinar platform, who has a vast experience, especially in terms of innovation, especially in terms of healthcare innovations. So thank you, everyone, and thank you to speakers for delivering an excellent lecture. So over to you, Mr. Gaurav.
Thank you, sir. So I would like to thank Mr. Oliulla also. He is, without his support, this webinar would have not been possible, because at the last moment we have asked him to support, and he is always ready to support us, giving the Zoom platform which he has to us, and it was possible because, with his support only we were able to come do this webinar. So thanks a lot, Ajit sir, Dr. Narottam sir, Vijay sir, and Dr. Rajesh Sinha sir, for allowing us to conduct this webinar. So thanks a lot, everyone.
Thank you, everyone, for
Thank you, Ganesh.
participating. And Mr. Gaurav, if any of the student team are having they have put any questions to the speakers, so just check.
So till now, I'm not seeing any question coming in the chat box. I will just check on YouTube if it is there any.
Because I'm sure, like, they would have at least few queries from our speakers, so that.
So there is one query, like one of the student wants to ask, okay, how does this e-laboratory works? This question is for Narottam sir. So how does this laboratory works, and how the student can do practical on that?
Basically, we are about to prepare one more lab. So we are little bit busy in that one. But from April onwards, what actually we did, for example, in our virology laboratory, we are isolating the RNA from H1N1. So that was live to the students also, so that they can learn like how to isolate the RNA. Very simple technology at home itself, without wearing the mask, without doing any good laboratory practices. They are entering into the virtually into this laboratory to learn the RNA isolation, then real-time PCR quantification. So we have already done these things. So if there will be like some of the students, those who are interested to do this e-laboratory programs, so on a request we can restart this one in October or in November itself. But I am praying that this will this lockdown will get over and we will be overcome with this COVID-19. But this was also a very good one, sir. During this lockdown, actually, all over India, from each and every corner of India, We were with the students. We started for botany, we started for zoology, for medical lab technology, for BMIT students, live demonstrations from this one, from the laboratory itself. What actually we did is in the March itself, because I left the job, then I started with my own laboratory. So it was very difficult for me to at least come up with these barriers. So what actually we did is more than 60 to 70 videos we have recorded of the practicals, like GLPs, there's DNA fingerprinting, profiling, staining, all the concerned practicals and protocols related to the laboratories. We have already this filmed, and we have prepared the videos of this one, and we give the voiceover to this one also, and we prepared the training manuals likewise for the medical lab technology students. Pathology, microbiology, serology, immunology practicals were totally different. Then for medical biotechnology, virology students, the practicals were totally different. Then we used to deliver all this stuff to the students. Even some of the universities and colleges, they tied up with the DNA laboratories in the form of MOU to complete their student dissertation training work online also. So we did that part. So this is how we managed this lockdown, and there were so many collaborations, and we means collaborated with so many good faculty members, good scientists, and all. So this lockdown was at least good enough in terms of this virtual-based learning for DNA laboratories.
Thanks a lot, Dr. Narottam sir. And now I don't see any other question here in the chat box.
Okay.
So we can close down the session.
Yes, yes, yes. So thank you so much, everyone, the participants and the
Thank you.
speakers. Once again, thank you so much.
Thanks.
Okay.